everyone, welcome back. In this video, we're going to talk about intracranial pressure, how it can be changed, and the outcomes of a change in intracranial pressure. We'll learn all of this by solving questions so that we're not only understanding things but also getting a fair idea of how these concepts would be tested. If you're interested in watching med videos, quizzes, productivity tips, interviews with doctors, and many other things related to medicine, do subscribe to my channel. You can also find me on Instagram. Question number 1. Which of the following can reduce the intracranial pressure? Option A, hyperventilation. Option B, hypoventilation. The answer to this question is hyperventilation. This is the brain and this is the spinal cord. Whenever there is an increase in PCO2 here, the body gets a signal that there isn't enough blood flow to the brain. So, it responds by vasodilation to increase the blood flow to the brain. An increase in blood flow here results in an increased intracranial pressure. So, if we want to decrease the intracranial pressure, we can achieve it by decreasing the blood flow to the brain. This is done by hyperventilation. When we increase the respiratory rate, we are getting rid of carbon dioxide by expiration rapidly. So, the PCO2 will be low. Since we have low PCO2, there will be vasoconstriction and the amount of blood getting to the brain will be decreased. This helps us reduce the intracranial pressure. Other ways to reduce intracranial pressure is by elevating the head of the patient's bed. This is done to increase the venous outflow. We can also reduce the intracranial pressure by providing mannitol. Question number 2. Which of the following is a part of Cushing Triad? Option A, hyperglycemia. Option B, hypotension. Option C, bradycardia. The answer to this question is bradycardia. Cushing reaction is a consequence of a rising intracranial pressure. It includes a triad by which our body compensates for a high ICP. The triad consists of hypertension, bradycardia, and irregular respiration. Let's find out how. Cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. Cerebral perfusion pressure determines the amount of blood the brain is getting. MAP is the pressure in the arteries. ICP is the pressure caused by fluids like cerebrospinal fluid in the brain. When the intracranial pressure is high, the cerebral perfusion will be low, so the brain will not get enough perfusion. In order to maintain perfusion, the mean arterial pressure will increase. An increase in mean arterial pressure is seen as hypertension. An increase in blood pressure is sensed by the baroreceptors. These further stimulate the heart to slow down and cause reflex bradycardia. Ultimately, a high intracranial pressure will interfere with the respiratory centers in the brain and lead to irregular respiration. In severe cases, this can also lead to apnea. Question number 3. A patient's left eye is facing downwards and outwards. His pupils are reactive to light. What is the most likely cause of this condition? Posterior communicating artery aneurysm or poorly controlled diabetes? The answer to this question is poorly controlled diabetes. Whenever an eye is in the down and out position, we should suspect a dysfunction of cranial nerve number 3. CN3 is responsible for adduction and for the upward movement of the eye. So, if there's a CN3 lesion, the eye will move in the opposite direction, that is, downwards and outwards. CN3 dysfunction can be brought about by either ischemia or by compression. What makes one different from another is the pupillary function. The part responsible for parasympathetic function of CN3 is on the periphery, while the somatic function of CN3 is controlled by the central part of the nerve. The parasympathetic part is responsible for the pupillary reaction, and the central part is responsible for eye movement. When there is an infarction, the central part is more likely to be affected as compared to the periphery. So, somatic function of CN3 will be lost, but the parasympathetic part of this nerve will still function. Hence, eye movement is lost, but pupillary reaction is intact in case of ischemia or infarct. On the other hand, when there is a compression, the entire nerve is affected. So, in such cases, the eye movement as well as pupillary response is absent. Poorly controlled diabetes increases the risk of infarction. Aneurysm of the PCOM as well as brain tumors can cause compression. Question number 4. Headaches which are worse with sitting up and get better with lying down are likely to be caused due to option A, high intracranial pressure, option B, low intracranial pressure. The answer to this question is low intracranial pressure. This condition is caused by a leakage of cerebrospinal fluid. It can happen when there's a tear in the dura, usually at the spinal cord. The tear enables CSF to leak out of the subarachnoid space, leading to a decrease in CSF in the brain. This is called intracranial hypotension. Low CSF results in attraction of the brain tissue and leads to headaches. Headaches get worse when the patient sits up because intracranial pressure decreases in such a position due to an increased venous flow while the patient is sitting. It gets better when the patient lies down. Hence, this is also known as postural headache. Intracranial hypertension, on the other hand, increases in intensity while lying down and decreases when the patient is sitting up straight. We've now come to the end of this video. If you like this and want me to make more neurology videos, give this video a thumbs up. If you want to try solving more questions on lumbar puncture, check this video out. And if you want to learn about dementia, do take a look at this video. Thank you for watching, and I'll see you next time.